Welcome back to the deep dive. Today we're looking at something maybe less glamorous but absolutely critical in the operating room. The endoscope assistant. You always picture the doctor, the one with the scope, right? But the flow, the speed, even the safety of that procedure, it often comes down to the assistant handling the tools. It's this real craft of anticipation and technical care. And we're basing this deep dive on some fantastic material from Dr. Raju's YouTube channel, specifically a video called HCC 1472 to 11 and 12 Endoscopy Technology Theory Handling Accessories. Really detailed stuff on the Gautamukula S. Raju channel.
Absolutely. And our goal here isn't just to talk about assisting, it's to really dig into the practical step-by-step know-how.
Got it.
How do you actually do this well? How do you avoid those little mistakes that can cause big problems and really smooth out the whole process?
Okay, so let's start at the beginning. Before anything even happens with the patient, the prep work. Our source says there are two basic things that just have to happen first to avoid, well, chaos.
Yeah, the first one sounds almost too simple, but it's crucial. Labeling specimen jars. The assistant needs to take the time before the procedure starts, label every single biopsy or specimen jar.
Why is that so critical right at the start? Can't just label as you go.
Well, think about it. Mid-procedure, things are moving fast. The assistant is focused on handling instruments, maybe getting feedback from the doctor. You don't want them also trying to remember, okay, which jar was for the stomach? Was this jar A or jar B?
Right, you want zero doubt at that moment.
Exactly. It just takes away a potential point of confusion, a potential error when things are really time-sensitive. It frees up their mental energy for the immediate task.
Okay, labeling first. Makes sense. What's the second foundational step?
Inventory, checking the supplies in the room.
Okay, standard procedure, check your tools. But there's a twist here, isn't there?
Yes, and this is where Dr. Raj's teaching really emphasizes foresight. You're not just checking supplies for the next case. You need to check that you have enough for all the cases scheduled for that room for the entire day.
The whole day.
Yeah.
Why so far ahead? Why not just restock between cases if needed?
Because if you discover you're short on, say, biopsy forceps or a specific snare during a procedure, or even just before the next one,
Everything stops.
everything stops. The endoscopist is waiting, the patient is under sedation longer than necessary, and the assistant has to break scrub or leave the room to run to the main storage. It disrupts the flow, wastes valuable time, and just adds stress. So the rule is, if the inventory check shows you're low for the day's total caseload, you go get those supplies before the first case even begins. Preparation prevents disruption. It's that simple.
Got it. So prep the jars, check inventory for the whole day. That sets the stage. Now let's move into the procedure itself. The assistant's role shifts to anticipation, right?
Exactly. This is where the mental game really kicks in. The assistant needs to be watching the monitor, seeing what the endoscopist sees a lesion, maybe some inflammation, and thinking ahead. Okay, they're probably going to need the biopsy forceps next.
So you're trying to predict the need before the doctor even asks.
Ideally, yes. Or at least be ready the instant they do ask. So when that moment comes, anticipated or requested, the handover process begins. First step, obviously, get the forceps out of the packaging.
Okay.
But the second step is one of those small details that makes a huge difference. You have to meticulously unwind any loops or kinks in the long catheter part of the instrument.
Unwind the loops. Why is that so important? It seems minor.
But it's not. Imagine the endoscopist receives the instrument and it's got a twist or a loop in it.
Okay.
They've got the scope handle in one hand, maybe manipulating controls, trying to maintain position inside the patient. And now they have to use their other hand, the one meant to insert the forceps, to untangle this wire.
Oh, I see. Especially if they've already started pushing it down the channel.
Exactly. If they've already fed part of it in, and then it gets snagged because of a loop outside, it's incredibly frustrating, slows things down, and can even affect their control of the scope tip. The assistant's job is to hand it over perfectly straight, ready to glide right in.
So unwinding isn't just tidiness. It's actively removing a potential obstacle for the endoscopist, reducing their cognitive load, basically.
Precisely. Now, linked to that perfect handover is safety. Dr. Raju is very clear about the closed handover rule.
Right. What does that mean, and why is it a hard rule?
It means the forceps must be handed over with the jaws closed, always. Many biopsy forceps have sharp points, sometimes even little spikes to grab tissue.
Okay.
If you hand those over with the jaws open, you risk accidentally pricking or even puncturing the endoscopist's glove or hand.
Yikes.
Yeah, it leads to, as the source puts it, unnecessary issues. It's a basic safety protocol. Breaks down trust if it's not followed.
So how does the assistant ensure they maintain that closed position during the handover? Is there a specific grip?
There is. The recommended technique is for the assistant to put one finger, usually the thumb, into the thumb ring on the handle, and then use their index and middle fingers pressing firmly on the sliding part, the groove. This actively holds the jaws closed.
Okay, an active grip and the receiving end, the endoscopist.
It's like choreography, really. The endoscopist will momentarily take their right hand off the scope controls, lift it slightly,
Yeah.
usually in a kind of partially closed grip.
Ready to receive.
Exactly. And the assistant needs to smoothly and precisely place the handle of the closed forceps right between the endoscopist's waiting thumb and forefinger.
Wow. Quick, seamless, no fumbling.
That's the goal. It sounds simple, but getting that smooth transition every single time takes practice and focus.
Okay, so we've got the forceps safely and efficiently into the endoscopist's hand. Now it needs to go down the scope channel to the target. There's a technique for helping with that too, right? Something about an arc.
Yes, the art of the arc. Once the endoscopist starts feeding the forceps into the biopsy port on the scope, the assistant's job is to manage the length of the instrument outside the scope to make insertion easier.
How does that work? You're not just feeding it straight in.
No. If you just hold it straight, there's resistance. The assistant needs to create and maintain a gentle, smooth curve, like a nice, wide arc with the flexible shaft of the instrument between the scope port and their hand.
A curve, like leaving some slack in a hose.
Exactly like that. A controlled loop or arc.
And why does that help?
That arc provides the slack and flexibility needed for the endoscopist to push the instrument down the channel, using long, smooth, efficient strokes.
Ah, I see. Without the arc.
Without the arc, or if the assistant holds it too tightly, the instrument binds. The endoscopist ends up having to use these short, jerky, inefficient little pushes. It takes much longer, it's more frustrating, and it requires way more effort to get the tip where it needs to be. Maintaining that arc is key to speed and ease of insertion.
That's a brilliant little detail. So the arc facilitates long strokes. Okay, now the forceps tip is visible on the screen near the lesion. What's the assistant doing now?
Now the assistant transitions roles again. They're holding the handle, and they become the direct control for the forceps jaws, based entirely on verbal cues from the endoscopist.
So the doctor calls the shot.
The endoscopist says, "Open the forceps," and the assistant simply opens their hand, relaxes their grip on the handle mechanism, and the jaws spring open on screen.
And close?
Close. The assistant closes their grip firmly, and the jaws snap shut, hopefully grabbing the tissue sample. The assistant is essentially the remote control for the jaws at this point.
Okay, biopsy taken. Now it's time to get the instrument back out. Are there efficiency tricks for retrieval too?
Absolutely. Once the endoscopist pulls the forceps tip back inside the scope channel, the assistant might be asked to pull the entire instrument, including its outer sheath, completely out of the scope.
Right.
To do this quickly, in just a few pulls, the assistant should actually stand slightly away from the endoscopist, maintaining a bit of distance.
Stand further away. That seems counterintuitive. Why not stay close?
Because standing slightly back gives you more room to use a longer pull. If you're right up close, your arm movement is restricted, and you can only pull the instrument out in short little increments.
Ah, so distance equals longer, fewer strokes, just like the arc helped with insertion.
Exactly. More distance allows for longer, smoother, more complete strokes, pulling the entire length out much faster. It sounds trivial, maybe a few seconds saved, but multiply that by 10 biopsies in a procedure.
It adds up, definitely. And one more point about retrieval avoiding spills.
Yes, crucial for cleanliness
Yeah.
and infection control. When that instrument comes out of the biopsy port or the biopsy cap, there can sometimes be a little bit of fluid or debris that comes with it.
Right.
So the assistant should always have a piece of gauze ready in their other hand, kept near the biopsy cap, ready to immediately catch any drips or spills the moment the instrument is withdrawn. Keeps the scope clean, keeps the area clean.
Okay, instrument is out, specimen potentially captured. What happens next? This sounds like where communication becomes absolutely critical.
Hugely critical. Once the forceps are out, the assistant has two really important communication tasks, according to Dr. Raju's teaching. Both are vital for diagnostic accuracy.
What's the first one?
First, they need to look at the specimen in the forceps jaws and immediately clearly inform the endoscopist about the size or quality.
How specific do they need to be?
Use clear, accepted terms. Loudly say, big specimen or good piece, maybe small specimen or small piece. This is direct feedback to the doctor.
And why is that feedback so important right then?
Because if the assistant says small piece, the endoscopist knows immediately, okay, that might not be enough for the pathologist. They might need to go back and take another biopsy from the same spot right away to ensure they get enough tissue for a reliable diagnosis.
Got it. And there was a phrase the source said not to use.
Yes, explicitly advises against saying a bad piece. It's just not constructive terminology in that setting. Keep it objective. Big, small, good. It's about providing actionable data.
Okay, so first, communication. Specimen size quality, what's the second crucial communication task?
This involves coordinating with the nurse, usually the circulating nurse who is documenting everything, often on a computer. The assistant needs to ensure the specimen goes into the correct pre-labeled jar and that the nurse records it correctly.
How does that work in practice?
The assistant, holding the forceps with the specimen, needs to clearly state which jar it's going into. For example, stomach biopsy jar A.
Okay.
And here's the genius part of the protocol. The nurse must verbally repeat it back. They must say, okay, stomach biopsy jar A, before they make the entry in the system.
Ah, the closed loop communication, like in aviation.
Exactly. It forces confirmation and catches potential errors. Imagine taking biopsies from the stomach, then the duodenum, then the esophagus, multiple jars, multiple entries. It's easy for the nurse to mishear or click the wrong line on the computer if there isn't that readback confirmation.
That simple confirmation step could prevent a disastrous mix-up down the line in pathology.
Absolutely. It's a critical safety net.
Now, before the forceps can potentially be used again for another biopsy, there's a cleaning step involving that specimen jar.
Yes, very important. The specimen jar contains formalin, the preservative. You absolutely do not want formalin going back into the patient via the scope or even getting onto the endoscopist's hands.
Right.
So after depositing the specimen into the formalin jar, but before handing the forceps back or preparing for another insertion, the assistant must clean the tip of the forceps, usually just by swishing it in sterile water and then maybe drying it slightly. Get that formalin off.
Okay, clean the tip, prevents chemical contamination. Makes sense. So procedure finishes, scope comes out. Is the assistant's job done with the specimens then?
Not quite. There's one final check. Dr. Raju emphasizes this is a joint responsibility between the assistant and the nurse. After everything is done, they need to do a final review of all the specimen jars.
What are they checking for?
Two things. First, physically look. Is there actually a specimen visible in every jar that's supposed to have one? Maybe one got dropped or missed. Second, double-check that the labels on the jars match exactly what the nurse has recorded in the patient's electronic record or log.
So it's a final verification that everything collected is present, accounted for, and correctly identified.
Exactly. It's the last chance to catch any errors before those samples head off to the lab. It ensures the integrity of the whole diagnostic process.
This has been fascinating. It really paints a picture of the endoscope assistant, not just as someone handing tools, but as an integral part of the procedural engine. It's about that intense preparation, the inventory, the pre-labeled jars. It's about the precision in handling unwinding loops, the closed grip, the arc.
And that high-stakes communication. Announcing the specimen size, confirming the jar ID with the nurse, it all ties together.
That technical pride really does translate directly into efficiency and safety.
It really does. And I think the key insight here, the real value of understanding these details, is seeing how tiny actions, seemingly small movements, have a massive impact. Creating that arc, cleaning the formalin, the readback confirmation, these aren't just nice-to-haves. They actively prevent errors, reduce procedure time, avoid injury, and ultimately ensure the diagnostic information is accurate. They eliminate points of failure.
It's all about minimizing friction in the system. So maybe a final thought for everyone listening. Think about that detail of the assistant standing slightly further away to pull the sheath out more efficiently. That difference is measured in maybe 2 or 3 seconds, a couple of wasted hand movements per retrieval. But mastery isn't always about the big dramatic moves. Sometimes it's about recognizing and optimizing those tiny fractional differences. Where in your own work, your own processes, could you find a similar tiny adjustment, like metaphorically stepping back half a step, that could unlock a surprising gain in efficiency? Something to think about.